Myself, Dr. JIBRAN Ahmad presents to you Simply Pathology, and today we are back with a very important lecture. Today we are going to discuss in details about hematopoietic stem cell transplant. So normally we have heard about heart transplant, lung transplant, liver transplant. Similarly, we also have hematopoietic stem cell transplant, in which it is a therapeutic procedure in which a normal hematopoietic stem cells from an appropriate donor are infused intravenously to the patient having defective or diseased bone marrow to reconstitute normal hematopoiesis. So, hematopoietic stem cell transplant is a therapeutic procedure in which the normal healthy hematopoietic stem cell from an appropriate donor is infused intravenously into the recipient or the patient who is having the defective or diseased bone marrow so as to reconstitute normal hematopoiesis. So, there are different types of hematopoietic stem cell transplant. For example, we are having allogenic hematopoietic stem cell transplant. So, it is a variety of stem cell transplant wherein the hematopoietic stem cells obtained from the donor are infused into another individual. Now, the other individual might be a family member, so they might be related or they might be unrelated. Okay, and for example, the matching between the two individuals, either they are HLA matched or they are HLA unmatched. Okay, so the second type of hematopoietic stem cell transplant is autologous variety of hematopoietic stem cell transplant, wherein the hematopoietic stem cells are obtained from the patient's own bone marrow or the peripheral blood, and after a period of processing and storage, it is reinfused back into the patient after treating the patient with the conditioning regimen. So, more in details will be understood in the later half of the video. What is the meaning of autologous hematopoietic stem cell transplant? Suffice is to know that in autologous variety, the patient itself is giving the stem cells. So, the source of stem cells in the autologous transplant is the patient itself, whereas in allogenic hematopoietic stem cell transplant, the source of hematopoietic stem cell is another individual. Now, syngenetic or syngenic, syngenic variety of hematopoietic stem cell transplant is a type of transplant which is occurring between two individuals who are genetically identical. That means when the transplant is taking place between identical twins, then we are calling it as a syngenic hematopoietic stem cell transplant. So, these are the three important varieties of hematopoietic stem cell transplant. So, first we are going to read about the allogenic variety of hematopoietic stem cell transplant. So, as we have already read about it, that allogenic variety of hematopoietic stem cell transplant is a type of transplant wherein the hematopoietic stem cells, which are HLA matched, is given from a healthy donor to the recipient. Now, this donor can be a family member or he can be unrelated as well. Now, remember, HLA matching is necessary to reduce the risk of graft rejection or graft versus host disease. So, if you are thinking what is HLA? HLA stands for human leukocyte antigen. Actually, I have already taught you about the concept of major histocompatibility complex called as the MHC. Now, every individual have their own, fingerprint on their cells, and that is basically, derived by the major histocompatibility complex or the MHC. So, every individual is having a unique MHC. Now, MHC in case of human beings are called as HLA, that is human leukocyte antigen, and therefore, every individual is having their very unique HLA, and no two individual will have the same HLA. So, whenever we are, giving or carrying out a hematopoietic stem cell transplant, we have to go for matching the HLA of the donor versus the HLA of the patient. So, HLA matching is the incidence or the chances of HLA matching is more with the immediate family members. For example, father, mother, brother, sister, between cousins. So, HLA matching is very necessary to reduce the risk of graft rejection or graft versus host disease. I will discuss in detail what is graft rejection, what is graft versus host disease. So, suffice is to say that HLA matching is an important component of stem cell transplant. Now, HLA matching can be, two types. It can be either a fully matched, HLA, or it can be closely matched. So, remember, only 30% of the patients have HLA matched donor sibling. Only 30% of the patients are having HLA matched sibling donor. Each sibling, remember, has a 25% chance for finding a complete HLA match. So for example, if there are two, brothers, or there are one brother, one sister is there. So if one of them is requiring a bone marrow transplant, then the chances that the HLA of the donor sibling will match with the recipient sibling is 25% only. Okay, so 1 in 4 siblings, okay, they have a chance for finding a complete HLA match between the siblings. So what are the important indications of allogenic hematopoietic stem cell transplant? Very importantly, the leukemias. Which kind? Acute myeloid leukemia, acute lymphoid leukemia, or acute lymphoblastic leukemia. Now AML and ALL, okay, in poor risk adult patients. Then chronic myeloid leukemia, myelodysplastic syndrome, severe aplastic anemia or primary immunodeficiency, hemoglobinopathies like thalassemia major, sickle cell disease, or inborn errors of metabolism. Okay, so these are the major indications. Now remember that allogenic hematopoietic stem cell transplant is quite a stressful procedure. Therefore, it is indicated in younger individuals. Okay, it is not indicated in older individuals. Now, what is the source? Now, in either kind, in any kind of hematopoietic stem cell transplant, okay, whether it be your allogenic or autologous or syngeneic, in any kind, you require hematopoietic stem cells, healthy hematopoietic stem cells. So, what are the sources of this hematopoietic stem cell that we are going to transplant? So, the number one source is the peripheral blood of the donor. The number two source is the bone marrow of the donor. So previously, what used to happen that the bone marrow harvesting used to be done from the bone marrow of the donor. But now with modern techniques, okay, it is possible to obtain the hematopoietic stem cells from the peripheral blood also. So the peripheral blood is currently the preferred method of harvesting the healthy hematopoietic stem cells. Normally, in the peripheral blood, very few hematopoietic stem cells are present. Therefore, to increase the concentration of the hematopoietic stem cells in the peripheral blood, administration of recombinant hematopoietic growth factor like granulocyte colony stimulating factor or granulocyte monocyte colony stimulating factor is required. So once you administer this growth factor in the specific or healthy donor, that is going to mobilize the hematopoietic stem cells from the bone marrow of the donor and enhance the levels of hematopoietic stem cells in the peripheral blood. Since such a hematopoietic stem cell transplant is done from the peripheral blood, therefore it is also called as peripheral blood stem cell transplant. Okay, remember that peripheral blood stem cell transplant is associated with more rapid engraftment. What is engraftment? I will explain you in details about it. Okay. So as compared to the bone marrow transplant, remember that peripheral blood stem cell transplant provides more rapid engraftment. Okay. Now, what happens over here? So, what is the basic process that we will see? So, whenever the growth factor is administered to the donor, okay. So, once we are going to administer the growth factor, that is the granulocyte colony stimulating factor, we are yet speaking about the peripheral blood hematopoietic stem cell transplant. So, what happens that we are administering growth factors to the donor. And because of the administration of growth factor, the concentration of hematopoietic stem cells in the peripheral blood in the bone marrow, the concentration of hematopoietic stem cells in the peripheral blood in the donor increases. Now we are subjecting the patient to apheresis. Apheresis is a process wherein we separate certain blood components as to our requirement. So over here we want to separate the stem cells from the blood, okay, and that is carried out with the help of a process called as apheresis. It is helping us in the collection of the stem cells. Once the stem cells are collected, we are going to evaluate the yield. So what is the process? How we can evaluate whether we are having a good concentration of stem cells in the peripheral blood harvest? We can go for a mononuclear cell count. Then we can also go for CD34 positivity of the cells. So how many cells are CD34 positive? Now one very important thing over here we have to understand is that at the hematopoietic stem cells, they are CD34 positive. Okay, they are CD34 positive. So the number of CD34 cells indicates the number of stem cells. And we can also go for assay for colony stimulating factor granulocyte macrophage or CSF GM. So the levels of this, all of these can indicate the yield. Okay, so the quality of the yield can be indicated by either the mononuclear cell count, CD34 plus cell positive count, and assay for CSF granulocyte macrophages. Then the second source of hematopoietic stem cell is the bone marrow of the donor. Now, very importantly, that bone marrow harvesting is done directly from several sites in the iliac crest, in the posterior superior iliac spine, and it is definitely a very painful procedure, so it is carried out under general anesthesia. Up to 1 liter of the marrow is aspirated from the donor, and the collected marrow is kept in a harvest bag which is containing acid citrate dextrose solution. Similarly, just like the peripheral blood hematopoietic stem cell transplant, the harvest from the bone marrow, bone marrow variety of hematopoietic stem cell transplant is also evaluated for adequacy by total WBC count. Okay, so these are the two very important sources of hematopoietic stem cells. Now, let us try and understand about the general principles of the allogenic hematopoietic stem cell transplant. So, there are several steps. The first step of hematopoietic stem cell transplant over here is conditioning. Conditioning is nothing but it is a process of administering high dose chemotherapy or total body irradiation to the recipient. By this particular process, we are killing all the malignant cells, and we are also creating a space for placing the healthy transplant hematopoietic stem cells. Now, the second thing, after conditioning, we are carrying out transplantation. So, it is at this stage that the healthy donor hematopoietic stem cells are placed in the recipient. The third process that occurs is the engraftment. So, engraftment is the process wherein the transplanted hematopoietic stem cells, they start to produce the blood cells and they start to become, functioning. And fourth is the immunoreconstitution. This is the last step of the allogenic hematopoietic stem cell transplantation, wherein all the immune cells, they enter the body. Okay, so very, very importantly, these are the basic principle of the allogenic hematopoietic stem cell transplant. Now, very importantly, just after the process of conditioning, there is an increased incidence of infection, which is one of the complications of allogenic hematopoietic stem cell transplant. Okay, and just at this process of engraftment, okay, it is at this step of engraftment that the other complication, that is graft versus host disease, starts to appear. So, what is GVHD? We are going to understand in the later half of the video. So, let us see the individual steps. So, the first step, as we can see, is conditioning. So, it is the conditioning process is carried over a period of around 1 week. Okay, the patient is administered high dose of chemotherapy, usually cyclophosphamide alone or in combination with total body irradiation. Okay, so what is happening over here, that we are administering high dose chemotherapy, or we are giving total body irradiation, or we are giving both, and this is being given to the recipient. Okay, so what is the idea? What is the use of conditioning? Number one function, it is eradicating all the diseased or the malignant cells from the recipient's bone marrow. Secondly, it ablates the patient's marrow, and it is creating a space so that we can place the marrow graft. So whatever healthy marrow that has been harvested from the donor, that can be placed in a space which is created by total body irradiation or chemotherapy. And the third very important thing is immunosuppression to prevent graft rejection. So by this process, all the recipient's immune cells are being destroyed. So the recipient's immune cells, they cannot go and attack the graft. So it is basically causing immunosuppression to prevent graft rejection. So these are the three very important functions of conditioning. Okay, so conditioning is administration of high dose chemotherapy or total body irradiation, or in combination of both, okay, to eradicate the malignant cells as well as to create a space in the recipient's bone marrow so that we can place the harvested hematopoietic stem cells from the donor. And not only that, by this process there is also immunosuppression of the recipient, because all the recipient immune cells are getting destroyed. Okay, and this is necessary so as to prevent graft rejection. Okay. Now, the second important step over here in allogenic hematopoietic stem cell transplantation is basically the transplantation. So it is the it is the process wherein the harvested stem cells from the selected healthy donor, whether it be from peripheral blood or whether it be harvested from the bone marrow. Okay, they are infused intravenously to the recipient. It is done 1 day after the completion of conditioning. Okay, now after conditioning, post conditioning, because after the conditioning process is done, so all the WBCs are also destroyed. So there is an increased risk of infections in the individual. So during the process of transplantation, what we are also doing, we are providing prophylactic antibiotic to the recipient, as well as we are keeping them in a filtered air environment. The third important step in transplant is engraftment, which usually occurs 7 to 21 days following transplantation. So in this step, the stem cells from the donor starts producing the blood cells in the bone marrow of the recipient. Okay. Then we are having the prevention of graft versus host disease and graft rejection. So first you have to understand what is GVHD. So GVHD is the condition when the donor T cell starts attacking the recipient, and graft rejection is when the recipient starts attacking the donor hematopoietic stem cell. Okay, so just try to understand, GVHD means graft versus host disease. Okay, so over here the donor's immune cell starts to attack the recipient, and graft rejection is when the recipient starts to attack the donor hematopoietic stem cells. So both these conditions are very bad, and if it occurs, it leads to increased mortality and morbidity. So how you can prevent it? You can prevent it by giving immunosuppressives to the patient or to the donor, to the recipient, like methotrexate along with cyclosporine is given and continued for 6 months. Okay, so as to prevent any GVHD or graft rejection. Then we also have to carry out, follow-up care is very important. So regular follow-up and care is very important so as to assess any long-term side effects or graft versus host disease or any presence of infection. So these are the basic steps or the basic principle of allogenic hematopoietic stem cell transplant. Includes conditioning, transplantation, engraftment, prevention of GVHD and graft rejection, and follow-up care. Okay. Now before I proceed with the complications of hematopoietic stem cell transplant, very important is a very important effect that we have to understand, that is called as graft versus leukemia effect. So what is this? So most of the curative effect of allogenic variety of hematopoietic stem cell transplant in the patients with leukemia, it occurs due to the graft versus leukemia effect, which is mediated by the donor lymphocytes. So whatever donor lymphocytes or a healthy donor harvest that we are giving to the recipient, the donor hematopoietic stem cells are rich in the immune cells. Okay, so what happens that those cells are very effective. So the donor immune cells are very effective in killing any residual malignancy or malignant cells which are present in the recipient. Thus, by doing so, they are decreasing the risk of relapse in the patients with acute or chronic graft versus host disease. So I will repeat once again. Okay, what is the graft versus leukemia effect? It is a very useful effect. Now the donor immune cells, see, the recipient doesn't have any immune cells because we have given high dose chemotherapy to the recipient. So the donors immune cells, okay, they are going to go inside the recipient, and if any residual malignant cells are present in the recipient, then they are going to go and kill them, and thus they will reduce the risk of relapse in the patients with acute or chronic GVHD. Okay. The second important thing is there's an increased risk of relapse in patients with lymphocyte depleted graft. Now sometimes if the donor cells or the donor hematopoietic stem cells, okay, if the donor hematopoietic stem cells are depleted of the lymphocytes, then as a result of of this, what is going to happen, that the donor immune cells will not be available, and because they will not be available, in that situation the risk of relapse of malignancy is becoming very high. So remember, graft versus leukemia effect is very important to decrease the risk of relapse in patients with acute or chronic GVHD. So they prevent any relapse of the malignancy for which the transplant is taking place. So what are the basic complications of your allogenic hematopoietic stem cell transplant? So the number one complication is because of the use of the conditioning regimen, that is the chemotherapy that we are using, or the total body irradiation. So there are two types. There is early complication, there is late complication. Early complications are those which are taking place in less than 100 days. Late complications are those which are taking place in more than 100 days. So what are the early complications? They are pancytopenia related conditions, like there will be bleeding, there will be reduced RBC, so there can be anemia. Along with that, there can be infections as well. Now, the second important complication is hemorrhagic cystitis. Then we have cardiomyopathy, alopecia, convulsions, veno-occlusive disease of the liver, oropharyngeal mucositis. Now, what are the late complications? The late complications include the cataract, which occurs because of total body irradiation, early menopause, sterility, osteopenia or osteoporosis, increased risk of secondary malignancies, as well as endocrine abnormalities. So this is the number one complication which is occurring because of the use of the conditioning regimen or the reagent. The second important complication over here is that of graft rejection. So let us try and understand what is the meaning of graft rejection. Graft rejection means that basically your recipient is not accepting the graft. It is rejecting the donor, or it is rejecting the donor cell. So it is basically carried out by the recipient's surviving immunocompetent T cells. So even after the use of conditioning reagent or high dose chemotherapy, sometimes immunocompetent T cells in the recipient might remain. And it most commonly occurs in presence of HLA incompatibility and insufficient immunosuppression. If the immunosuppression is not proper, or if there is a lot of incompatibility or lot of mismatch between the HLA of the donor versus that of the recipient, in that case, graft rejection becomes, the chances of rejection becomes very high. Most commonly, it is seen in patients with aplastic anemia or in patients who are sensitized to HLA antigens by previous blood transfusions or T cell depleted graft. So there are conditions which can increase the risk of graft rejection. For example, patients in whom aplastic anemia is there and that is the indication, so in them the chances of graft rejection becomes very high. Second is patients who have received previous blood transfusions, so they are sensitized to the HLA antigen, so HLA mismatch becomes very high. And suppose if the donor graft actually doesn't have any immune cells, so they are quite vulnerable to attack by the recipient, and that also leads to graft rejection. Okay, so the third important complication is graft versus host disease. Now this is the opposite, wherein the donor hematopoietic stem cells, the donor immune cells, they go and they attack the recipient. Okay, that is graft versus host disease. So the immunocompetent T lymphocytes in transplanted graft attacks the recipients. Okay, recipients are immunodeficient. Why they are immunodeficient? Because we have already given them conditioning therapy. So as a result, they are completely vulnerable. There is a pancytopenia in them. So most commonly, graft versus host disease occurs in unrelated hematopoietic stem cell transplant or HLA mismatched transplant. So that is why it is very important that HLA matching is done before doing the graft, before carrying out the transplant. Why? Because if HLA is not matching between the donor and the recipient, the risk of graft rejection and graft versus host disease becomes very high. If we look at the graft versus host disease, again there are two types. One is the acute variety, which occurs in less than 100 days, and the chronic variety, which occurs in more than 100 days. So acute variety presents in the skin as maculopapular skin rash, in the liver as cholestatic hepatitis, in the GI tract as nausea, vomiting, diarrhea, and ileus. Now, acute variety of GVHD, it delays the recovery of the immune system, so there is an increased amount of infections. The diagnosis of acute rejection or acute GVHD, is by biopsy of the involved organ. For example, we take the biopsy of the skin, liver, or GIT, and we see that really there is a rejection and acute rejection is seen. How you can prevent acute rejections? By use of immunosuppressives, T cell depleted grafts. Okay. Now, very importantly, in case of chronic GVHD, the diagnosis again is done by biopsy. Clinically, such biopsies from such patients, it resembles any autoimmune disorder like SLE, biliary cirrhosis, or Sjogren's syndrome. Again, the treatment is same, to give immunosuppressives like corticosteroids. The next complication occurs, that is the infection. So in the early neutropenic period, there is an increased amount of bacterial, fungal, and HSV infection. After engraftment, there is CMV pneumonia. So after engraftment, there is an increased chance of some kind of infection like cytomegalovirus pneumonia, and in the later phases, infection by varicella zoster and encapsulated bacteria are more common. The last complication that occurs is the recurrence of the malignancy for which the transplant was performed. So recurrence of leukemia, less likely to occur when Hsct is done during the first remission than in advanced disease. Okay, so these are the 5 very important complications of your allogenic variety of hematopoietic stem cell transplant. Okay, and with this we have completed in details, okay, the definition of allogenic hematopoietic stem cell transplant. Then we had basically seen the the source of the hematopoietic stem cells, what are the indications of doing this particular test, the general principles and the steps of how it is carried out, and what are the complications. So after having understood the allogenic variety of hematopoietic stem cell transplant in details, now we are going to start with the autologous variety of hematopoietic stem cell transplant. Now, stem cells previously collected from the recipients are infused back into the recipients. That is, the patients are serving as their own source of stem cells. So, what are the indications? When is it that we are going to carry out autologous variety of hematopoietic stem cell transplant? In case of relapsed aggressive non-Hodgkin's lymphoma or relapsed Hodgkin's lymphoma, plasma cell myeloma after induction chemotherapy, mantle cell lymphoma in the first remission, solid organ tumors, example breast carcinomas or germ cell tumors, AML in second remission if allogenic donor is not available. In that case, we have to carry out autologous variety of hematopoietic stem cell transplant. So, the basic principle is the same as we are seeing over here, that is, we are having the steps of conditioning, transplantation, engraftment and immunoreconstitution. But very importantly, here the stem cells are harvested from the patient itself beforehand, okay, and then they undergo processing and storage so as to kill all the diseased or the malignant cells. And after that, they are basically, transplanted to the same recipient. It is transplanted to the same patient from where it was harvested. Okay, that is why it is called as autologous variety. Again, over here, just after the conditioning, the incidence of infections becomes very high, and if just after the engraftment process, the chances of relapse of the disease is very high. So remember one thing, in autologous variety of hematopoietic stem cell transplant, the most important complication is relapse, whereas in allogenic variety, the most important thing is GVHD, okay, graft versus host disease and graft rejection. So over here, what are the steps? The stem cells are obtained from the patient during complete remission. So when the patient is in complete remission, in that time, the stem cells are harvested from the patient itself. The harvested stem cells are then processed to remove any contaminating malignant cells, and they are cryopreserved by freezing it in liquid nitrogen. Subsequently, the stem cell transplant is done within few days or years of marrow harvest. Now, conditioning or high dose chemotherapy begins within few days or weeks of the marrow harvest. So, the patient just in a few days or weeks after the marrow harvest is now going to receive high dose chemotherapy so that we can kill all the hematopoietic or the bad cells, which are bad hematopoietic cells which are present in the bone marrow. So this is the conditioning that we carry out, very much similar to allogenic variety. After a day of conditioning, the stem cell product, that is the one which was basically obtained, that is the one which was obtained from the patient itself, is rapidly thawed and infused intravenously to itself. So the patient's the patient stem cell which was basically harvested, okay, prior some time, is now thawed and it is again infused to the same patient. So what is the comparison with the allogenic hematopoietic stem cell transplant? So compared to the allogenic variety of hematopoietic stem cell transplant, the intensity of the conditioning regimen is less over here. The immune restoration is quite quicker, and there is no potential for GVHD in case of autologous variety of hematopoietic stem cell transplant. So these are the advantages of the autologous variety. Here the intensity of the conditioning reagent is quite less, so autologous Hsct can be performed on older individuals, and because they will be better able to tolerate this variety. Now the immune restoration is much quicker compared to the allogenic variety, and because the same patient stem cells are basically treated and then infused back in the patient, so there is no chance of graft versus host disease or graft rejection. Therefore, the procedure is suitable for older patients. The most common complication is relapse of the underlying malignant disease. That is the most important problem. Why it is the most important problem? Because if you see that we are basically processing the donor and the recipient is the same. So that particular harvest that we are taking from the recipient is basically treated and processed. So the harvest or the transplant material is devoid of any immune cells. So that is why graft versus leukemia effect is not seen in autologous variety, and as a result, the chances of relapse is very high in the autologous variety of hematopoietic stem cell transplant. So what is the disadvantage? As I told you, because the donor and the recipient is the same person, so whatever stem cells are harvested first, they are itself treated, and as a result, the donor or whatever harvest material that we have obtained, and after processing, they do not contain any immunocompetent T cell, so there is no graft versus leukemia effect which is seen, and as a result, the chances of relapse becomes very high in the autologous variety of hematopoietic stem cell transplant. Second important is that sometimes you might have a problem in harvesting the patient's own stem cells. So that is, as a result, this procedure may not be able to carry it out. And such patients after transplant, they have a high risk of development of secondary hematological malignancies. So these are the disadvantages of the autologous variety of hematopoietic stem cell transplant, and these are the advantages of the autologous variety of hematogenic stem cell transplant. So what are the complications? Remember, the complications are very much similar to the allogenic variety of hematopoietic stem cell transplant, but they are far less frequent and they are less severe. Okay, the most common late complication is the relapse of malignancy that we see, and remember, GVHD is not commonly seen with autologous variety of hematopoietic stem cell transplant. So we have completed the discussion of allogenic and autologous variety of HSCT. Now we are going to compare and contrast both of them. So if you look at the features, number one, the source of stem cells in case of allogenic variety, it is a family member or it might be an unrelated donor. So it is another individual, whereas the source of stem cells is provided from the recipient or the patient itself. If you look at the age, it is better suited for younger patients less than 55, whereas a wide range of individuals, can use autologous in young as well as in old. But in older individuals, autologous variety of HSCT is more preferable. The main indications, as I have already spoken about, is AML, ALL, CML, MDS, primary immunodeficiency or hemoglobinopathies, whereas over here, the main indications are relapsed NHL or HL, that is relapsed non-Hodgkin or Hodgkin lymphoma, multiple myeloma, and in case of solid tumor. The risk of contamination of the graft by malignant cells is completely absent over here, whereas the risk of contamination of the graft by the malignant cells is present, because over here the donor is completely healthy. Okay, but over here the recipient and the donor itself is same, so there can be a chance that the malignant cells remain in the harvest. So the risk of contamination of the graft by malignant cell is high in case of autologous variety. Now, as I have already spoken, the GVHD risk and the graft versus leukemia effect are present over here, whereas these risks are absent over here. Why they are absent? Because already the patient and the recipient and the donor, they are same. So whatever material we are harvesting from the recipient, we are actually processing it, and therefore whatever harvest we are going to give to the patient itself, they are devoid of any immune cell. So as a result, the chances of GVHD and graft versus leukemia effect is nil in case of autologous variety, and as a result, the main complication over here is relapse of the malignancy, whereas over here the main complication is graft versus host disease. Now, the overall procedure related mortality over here, if you see in case of allogenic variety, is 20 to 30% for HLA matched, bone marrow transplant, whereas it is 45% in, in case the transplant is between unrelated individuals. Okay, and the overall procedure associated mortality is quite less in the autologous variety. It is around 5 to 10%. The risk of inherited disease, okay, if you see, not the risk, the treatment of the inherited disease is possible with the allogenic variety, whereas it is not possible with the autologous variety. Restoration of immune function is slower in the allogenic HSCT, whereas it is rapid in the allogenic autologous variety. So with this, we have completed in details the the allogenic versus autologous variety of HSCT. And now we are going to end this lecture by throwing light into certain recent advances. So there are two more kinds of transplant, stem cell transplant which is there. One is your umbilical cord blood transplantation, and another is non-myeloablative allogenic variety of HSCT. So first we are going to understand the umbilical cord blood transplantation. So umbilical cord stem cells are readily available source of stem cells. Now, since immunocompetent cells are immature, therefore the risk of GVHD with umbilical umbilical cord stem cell transplantation is very low. The number of stem cells in umbilical cord is quite limited, and most successfully this kind of transplantation has been carried out only in children. Now, the other variety, that is a non-myeloablative variety of allogenic HSCT. It is a type of allogenic variety only, but basically whatever conditioning reagent that we are using is very mild. So it is inducing immunosuppression which is sufficient to cause engraftment, but they are also inducing slow generation of graft versus leukemia effect. So the basic idea of this kind of a combination of using a mild conditioning agent is that we can make allogenic variety of HSCT more acceptable to the patient. So it becomes less toxic, causes less mortality and less morbidity, and there is more graft versus leukemia effect that is required to treat the relapse. And this non-malablative variety is suitable again for older patients. So with this, we have completed the discussion of hematopoietic stem cell transplant. Thank you very much for watching this particular video.